and welcome to the Postpartum Years podcast. I'm your host, Dr. Mary Ellen Kramp. I am a physical therapist and a pelvic health specialist. Today, joining me is Vanessa Pinkham. She is a Pilates instructor and an instructor for Pilates instructors. She goes far beyond Pilates as well as far as her exercise educational experience. But I won't go deeply into that. I'll put that in the show notes. So if you want to look up on that, so I don't have to do a half-hour intro on her, that'll be good.
Thank you, Mary Ellen. It's such an honor to be here.
Yes.
And I'm excited about the subject matter because it's something near and dear to my heart.
Yes. Today we're going to be talking about diastasis recti. And I think the biggest thing is, do you say diastasis or diastasis? And there's no consensus. Say it whichever way you want.
How do we have an agreed upon usage by yourself so that we're consistent for the podcast?
No.
Okay. I say diastasis. So whatever.
I hear it both ways all the time. So I honestly go back and forth.
Awesome.
All right. So for those of you that don't know what that is, it's a separation in the abdominal muscle. So if you think of the six pack is like 2 3-packs because there's a lot of space in between. You know, the rectus abdominis, instead of kind of almost touching in the middle, there's space. And in the research, more than 2 centimeters is a diastasis. So it's basically if there's an inch of space in between, according to research, that's going to be a diastasis. What I see postpartum is the split in the abdominals is above the belly button. And that is quite common. Going through the belly button is also quite common. And it can even be the entire length from the rib cage all the way down to the pubic bone, where those abdominals are further apart than they should be. As a therapist, I treat a lot of these women because there's usually a lot of restriction that's going on that's preventing those muscles from coming together. Sometimes there's a hernia. Sometimes the connective tissue just isn't holding everything together really well. In some cases, it's a surgical thing. In some cases, I can correct a lot of things. But no matter what, at some point, they need to see Vanessa.
Thank you.
So the exercise
or a colleague.
I think everybody should see you. But
I need a lot of minions.
Yes. So make yourself some clones.
Thank you.
I want a couple of them up here, please.
Doing my best. This will help.
So, from my perspective, I really like to treat these people first and make sure that they are doing as best as they can from an ability to fire the muscles. So I'll just explain first how I evaluate someone with this. I use ultrasound. So I will look at the abdominal muscles with an ultrasound. I will look at the rectus abdominal muscles. I will measure the distance between the rectus abdominal muscles on the ultrasound. Sometimes I can't even measure it because they're so far apart. I cannot actually measure the distance. I will have the person raise their head so I can watch the abdominal muscle, the rectus abdominis, contract. If it does, sometimes it does not. I will look at the other abdominal muscles, which are the external oblique, the internal oblique, and the transverse abdominis muscles. I will put my ultrasound on top of where I can see all 3 of those at the same time, and I will have the person lift their head and shoulders and see how those muscles contract. In many, many cases, the internal oblique is doing all of the work, while the external oblique and the transverse abdominis are just kind of sitting there going for the ride.
And you're using the ultrasound in this instance because you trust, and I imagine that it's also building confidence in the patient because you're looking at it visually. You're not just relying on palpating
Right.
the muscle while firing.
Right. Or just watching
Okay.
them and yeah, that looks good. Um, I'm I am physically watching them. I have them holding the iPad because I have an ultrasound that hooks up to an iPad. I have them hold the iPad and I show them where the muscles are. I have them lift their head and shoulders and show them how the muscles are contracting. And then based on how they're moving, I'll do different releases. We'll look at it again, see if that's changed. And from my perspective, when I get them to a point where they're contracting everything as they should. Sometimes it can just be a matter of then getting to, an exercise program. And yes, as a PT, I could bring them through that. But I'm going to say that part bores me to tears.
I love your honesty, and I actually respect and appreciate it. I really do. I get it.
Yeah. So that part, I don't feel like I'm as good as of a therapist as I could be for that aspect. So I rather them see somebody else. And I'm a total snob when it comes to the hands-on therapy, and that's where I shine. That's where my passion is. So I make sure that everything is firing appropriately, and then I hand them off to somebody like Vanessa to manage the next part. So
Fantastic.
Vanessa, tell me what you do. I mean, what do you want people to know as far as diastasis and Pilates or any other exercise?
As it relates to diastasis, I think that what is often the complaint that I hear from most patients coming from a clinical practice, if they took it upon themselves to be assessed, is that they have a tremendous amount of fear that they are going to make the area worse. It's introverting. It compromises their sense of aesthetic. As, in the case of like a first baby, they're shocked that their stomach didn't bounce right back, like the social media influencers that they follow that show 8 weeks postpartum and their belly is flat and everything's back together. And there can be instances of that, but it's few and far between. The healing time, which you can speak with more education than I can, the healing time is months, and the full healing can be years for some. But as it
Mm-hmm.
relates to the separation of the abdominals, there has been so much misinformation that by doing abdominal curl ups, that it is going to make the separation worse or greater. There was the plank controversy of the last 5 to 10 years. Do planks make them worse? Do planks make them better? They do neither. They are putting mechanical tension on the tissue, which is in all instances positive. So when people come to me, they have a DR, whether it's been there from a recent delivery or their baby is 30 years old. What I seek to accomplish is an understanding of where their body is in space, specifically within the trunk, movement of the rib cage, movement of the sternum, and then establishing a baseline of strength that we can then build on. So with DR, if the person has a visibly prominent separation, they have a great deal of concern about it, and they are stating that they're experiencing pelvic floor dysfunction of any kind, I outsource. I'm not a doctor. I'm not a physical therapist. I'm not going to pretend to be one. And I feel that in the Pilates industry, it devalues our work when we try to step outside of the scope of our practice. So when Mary Ellen was here, had someone to send my people to. I am still on the hunt for a person that I can have a rapport with that I did or that I have with you. But there are good practitioners in the area, and I'm grateful that they're here. We miss you here, but it's wonderful that you're in DC and you're able to help a whole new group of patients. So for me as an instructor, if a person is newly postpartum, I'm looking to get the person to have an overall sense of increasing strengths. I do not pathologize the DR. If it's present, I do seek to have them assessed so that they can understand exactly to what degree is present, and then they can go back to that person and see that over time if it has changed, if it hasn't, what they can or can't do about it. And again, what I might understand clinically through my own research as a movement educator for over 20 years now, what I understand clinically does not and should not carry over into what I speak to a client. At the end of the day, I am a certified Pilates instructor and a certified personal trainer. And that's my wall. So I play dumb. And I do that because it is protective, not just to me as a practitioner, but it's protective to my industry so that we are not stepping outside of the boundaries of all that we can create within here. So I look to get them to feel that they can curl up with the help of a spring-loaded deceleration. So elongating movements, eccentric movements, where they are not tenting. And I call it loaf of breading, where the rectus abdominis pumps up like a loaf of bread, and allowing them to feel that when they bend laterally, that their obliques are firing and the intercostals are internally and externally rotating the rib cage. And as that awareness begins to build in a person's body and the strength begins to build, I then add a little bit of progressive overload, either with the spring in the Pilates studio or with a little bit of weight, so that we know through strength and conditioning research that we're allowing the muscle to be progressively loaded. In my experience, consistently, when the glutes, abductors, abdominals, spinal musculature, chest and back are worked as a system and as a team, I never cue the pelvic floor. I don't mention it. I don't say it. And I don't know what your thoughts are on that, but I'm curious how you feel about that, because I stopped cueing the pelvic floor. My daughter is 11 years old now. I stopped cueing the pelvic floor 10 years ago. So I'd like your viewpoint on why.
Yeah, that's one thing that's kind of been a pet peeve of mine as a pelvic floor therapist. Where
Why is that? Because, I feel like instructors feel, they finish their reformer 1. They learn all these exercises and they're ready to start teaching a group class. And part of the cueing of the abdominals is to first lift the pelvic floor. Exhale, lift pelvic floor. Pull your navel toward your spine, knit your ribs together, shoulders back and down. So where's the problem in that?
Well, where I see the problem is so many women that I treat where I will have a finger in the vagina.
Glove on, hands in the vagina.
Glove on, yep. Finger in.
Is this woman fit? This is not like a 60-year-old grandma.
I could take anybody off the street. So I could put a fit person on my table. So an athlete, I've had, the 60, 70-year-old women. I've had, the person who's deconditioned, because 60, 70-year-olds can be quite fit. So, the spectrum, those that have not had kids, those that have had kids, and asking them to contract the pelvic floor, a huge portion of them are not able to contract the pelvic floor. I know some,
You're palpating their muscle internally, and they cannot contract.
So they have the stimulation of my finger there, and where I could say, okay, if I had my finger on your hand and, contract that muscle that I'm touching, most people would be able to do that. Not everybody can, wow. But I know some research from years ago said 70% of people are not able to accurately contract the pelvic floor when cued to. So this is why,
I can't even feel it.
Right. I am a certified yoga instructor. When we were learning that, it was making me cringe when they were talking about pelvic floor stuff, knowing that 70% of people just don't contract properly. There are some people who, it may be because they're deconditioned. It may be because some people just aren't very well aware of their own bodies. I'll ask somebody to wiggle their toes
Mm.
and they move the ankle instead. For the pelvic floor, I will ask them to contract the pelvic floor and the glutes go, or the adductors go, or anything else happens except the pelvic floor.
But the pelvic floor.
Right.
So, okay, so you're a clinician. You've got a glove on. You're physically touching the muscle.
Mm-hmm.
Like that's one hell of a touch cue. You're touching the muscle and they're still not firing it. So then I, as an instructor, am standing before a class of a 70-year-old grandma, a D1 athlete, a woman who's 2 months pregnant, maybe doesn't even know it. And I'm telling them all to engage their pelvic floor. And potentially 70% of them are incapable of even identifying what that means.
Right. Right. I mean, the pelvic floor muscle is, those muscles contract subconsciously. So
They should.
they
They
should.
should.
They should. So if you cough, if you sneeze, if you laugh, orgasm, whatever, those pelvic floor muscles are going to contract on their own. As you go to bend over to tie your shoes, things are going to happen. You go to lift something. If you're playing the French horn, they should, they should be engaging subconsciously all the time, just kind of like posture. You're not terribly aware of what your posture is. You can change your posture actively.
Superficially.
You can contract the pelvic floor actively, but not everybody should be doing those Kegels and engaging the pelvic floor with ab exercises. So someone who has vaginismus, like any sort of pelvic floor pain,
What is vaginismus?
it's a spasming of the pelvic floor. Some people, they may have had sexual trauma. They may have had other trauma to the pelvic floor. They may be unaware of any trauma that they might have had to the pelvic floor. But there's a spasming that can happen, and a lot of these women aren't able to have sex, or if they do, it is painful. There are other issues too, vestibulodynia. People just with general pelvic floor dysfunction, a lot of them tend to hold really tight, and then asking them to Kegel on top of that can end up causing them more pain. In addition, you can contract different parts of the pelvic floor. So you can contract more toward the front and focus on like around the urethra. You could focus more centrally, like if you were to, not to be crude, but like if you were to grab around your partner's penis and squeeze that way. You can contract more toward the back, like if you're trying to hold in a fart. So there are also different ways to contract the pelvic floor and different focuses within the pelvic floor and where you want them to contract. And somebody who has like coccyx pain, you don't want them doing a ton of Kegels because those pelvic floor muscles attach back to that coccyx.
So they're short and tight.
Yes, yes.
And then you're tightening. It's almost like telling a person who has TMJ to grind their teeth. And saying that it's beneficial.
Yeah.
Wow.
So there's a population of patients where, yes, I'm actively trying to teach them how to strengthen the pelvic floor, but there's a population where I'm actively discouraging them from trying to contract. And we're going to work on bulging. We're going to work on pressing down rather
you want
than
them to stretch it and relax.
Right. I have to teach them how to relax it versus how to contract it.
And not to go on a tangent, but as the rhythm of the pelvic diaphragm and the respiratory diaphragm, are they subconsciously moving in unison in a healthily functioning pelvic floor?
Right.
Cough, sneeze, laugh. That's what I was thinking with. So if you have someone whose tailbone, whose coccyx is functionally tight, and you're cueing them every time that they go into flexion to tense that area, could that then structurally have a negative effect on their respiratory cycle when done with enough repetition?
Well, I mean, yes. And I mean, just think pain anywhere. the
Mm-hmm.
tension that happens throughout the trunk, if I were to punch you in the gut,
Yeah.
you know, your whole diaphragm, the rib cage is going to tense in response to that. You throw that down to the pelvic floor and in the coccyx or the sacrum, yeah, that's going to go up the chain as well.
So this is incredibly validating for me professionally because my viewpoint, which was further reinforced for the viewers, I came to Dr. Kramp as a patient. And I came to her when my daughter was around 4.5, 5, because I did not have postpartum pelvic floor discomfort or weakness. Mine came later. And mine was not from pelvic floor weakness, which I presumed it was. That was the ethos that I existed within, and therefore a weakness that I felt. I was at the end of a triathlon. I had chugged water on the bike. You swim, you bike, you run. And I was chasing down a woman who had a 54 on her calf, which means she was 54 years old, and she was outrunning me, and I was 30 years old. I wasn't about to have it, and I'm sprinting. And in my sprint, I felt like I was going to pee my pants. I felt like I could not physically hold my abdominal muscles in, which was my computation. You squeeze it tight and strong and hard enough, the muscles stay where they're supposed to. And what I hadn't understood was that through the amount of volume of tensing my pelvic floor, contracting my abdominals, and my own increasing Pilates practice postpartum, I had created so much tension that there was no further squeeze to do. And so with the cue of a full bladder, I had nothing else to squeeze. Boom. So I had to unlearn my patterns of tension and relearn how to actually bear down and stretch and relax. And that was so hard for me. It made my labor longer than it needed to be because I kept sucking my daughter back up. She'd crown, I'd squeeze back up. I didn't know how to push.
Right.
Until, the contraction of the uterus was enough that I was able to get my daughter out. So cycle back to the present. When I decided to flat out stop cueing the pelvic floor was I realized that because I had no idea of each person in the group classes that I was teaching, what was happening internally with each person, it made no sense to cue that. Even more so in private sessions. And not only did I not feel clinically responsible, but I actually felt irresponsible and dishonest. So I stopped completely. And only once in a while, people who do a lot of group classes will notice you never cue the pelvic floor. And it gives me an opportunity to explain why. That I would no sooner, and please excuse my humor, I would no sooner cue a group of women to first orgasm on their exhale than I would to contract their pelvic floor and then continue on. It makes no sense. It should be an automatic subconscious reaction to cough, sneeze, laugh, even a slow, long exhale. There should be a little gradual lift. And if that's not happening, I can't clinically assess that. I don't have a glove on randomly assessing patients because I don't have that education. And who would go to a group class where you're randomly being vaginally assessed? That would be wild. Right? Super. I mean, you could teach that class, Mary Ellen. I don't know who would come, but it would be fascinating. Whew. So
Yeah.
yeah. But I think this is a really eye-opening conversation because it's not from a place of malice. It's a place of incompetence that Pilates instructors at large are cueing the pelvic floor and I know as a teacher, what we thought we were doing was by cueing the pelvic floor, we were somehow creating greater tension that would then carry up and into the lower abs. Engage the pelvic floor, the lower abs, or the transverse abdominis fires more.
Right.
But as we know in clinical research, the more that the pelvic floor fires, in the presence of a DR, a diastasis recti, the DR will spread a little more on the contraction. So not only are we not helping those who potentially have a bit of structural dysfunction in their abdominals, but we can't even know if they're doing it correctly. So why cue it in the first place?
Right. Right. Yeah. and the abdominals and pelvic floor are definitely related. When I see a patient with diastasis,
Mhm.
so frequently, there is also some sort of pelvic floor dysfunction. And those people are probably not, you know, many in a Pilates class don't know they have a diastasis. I
Right.
see a lot of women 25, 30 years postpartum who had no idea that they had a diastasis. Um, but a lot of pelvic floor dysfunction goes right along with it. So they're aware that they now pee when they cough and sneeze. They're now aware that um, they they may be aware they have a prolapse. They may find it more difficult to poop because the
Wow.
rectum is falling forward after that delivery. So there's definitely, and it's the connective tissue. It's not only the pelvic floor. The pelvic floor is at the bottom of all of that. Um, so yeah, there's a component with the pelvic floor, but there's also a major component with the connective tissue. Like
Okay.
the reason the rectus abdominis muscles aren't together, you have connective tissue in between them, and connective tissue has the ability to be turned on and supportive or off. And when it's on and supportive, there usually is not a diastasis.
Mm.
When it's off, there's a diastasis, there's pelvic floor dysfunction, there's often prolapse. And they do go hand in hand. And in some people, I've found the magic buttons to turn everything back on. Others, it's a surgical issue, and I
Mm.
have to refer them out for surgery. And we have even more to talk about. So we will be continuing our conversation next time. This is the Postpartum Years podcast, and we'll see you next time. Thank you.